Okay, the title of my talk is Gustaki Maaf Replacement Surgeon G. Into English, if we translate, pardon me, all specialized joint replacement surgeon. I'm going to show what joint replacement surgeon, when he treats a fracture, what happens. This was a replacement done beautifully. He was going on very well. Hip was good. Patient got a fracture. Patient got a fracture, surgeon did properly or improperly, whatever it is, the surgery, did it with the leg screw. This was a primary surgery. 3 months, it gave way. So he did a second surgery. He removed it, put another plate, another graft. Third surgery, and this also broke down. Now, joint replacement surgeon knew how to do a revision hip. So he went ahead and did a revision hip on this, and here also still the fracture is not united, because he took it for granted that when we put in a bypass stem, it's enough. It's not enough. This can give way and the whole prosthesis can break. So if we can analyze why it failed, first and the foremost, the joint replacement surgeon, extremely good joint replacement surgeon, did the surgery of his 20-year-old knowledge. Unfortunately, he didn't involve any trauma surgeon. Now this is what happened. Possible reason, this is a short oblique fracture. And a short oblique fracture is, leg screw is contraindicated. You cannot put a leg screw in a short oblique fracture. So this is what he put in. And as you can see, this is a short oblique fracture. He put in the leg screw, so this small part of the bone becomes necrotic. This is exactly what happens. It became necrotic. So this is what it was done. It became necrotic, and this is the dead bone here. He didn't do anything. He went ahead and did the second surgery by putting more graft. The dead bone is a gap, which I presume he should have taken out with the corticocancellous bone and put in the surgery what he did it. So this is where it is. If it is a short oblique fracture, leg screw is done in this humerus or any bone, and this is what it happens, and it comes out, and you can see there's a small sequestrum comes out, because that small piece, when you put the screw, becomes dead. So in trauma, we know it very well that short oblique fracture should not be treated by a leg screw. So now, he should have, instead of doing the block graft, he should have taken out a block graft, taken out the dead bone, taken the block graft, and probably supplemented with the second plate there, because there was a block, which he didn't do it. And here it is. This is the case which I had treated. I had done these 2 surgeries, and there is a long oblique fracture. Long oblique fracture must be treated by a leg screw. So excellent leg screws and a neutralization plate, things becomes all right. Now here is the second case, identical thing, replaced by, it was a short oblique fracture, comparatively small piece here, did the leg screw. This is exactly what happened, broke down, and ultimately the trauma surgeon treated it, removing everything, putting in a bone graft, and the things were all right. This is exactly what happens if you are not treating the patient normally all the time. Both these cases, the short oblique fracture treated with the leg screw, and bypass surgery, the patient is still walking about, but you don't know how long it's going to last. I have 2 cases which I have seen, bypass surgery, ultimately the stem bends down. Now here it is, another surgeon did this surgery for a short oblique, for a fracture below thing, retaining the hip joint. And after doing the surgery, it's a short plate. This short plate, and actually the stem is there, so he's not holding it properly. So it has been, we all know it very well, that the plate has to go right up to the GT. If it goes right up to the GT, then it can have a hold in the proximal fragment. Otherwise, it will not have a hold. So this is what it is. If you go and do a plate, because there are half plate, it will be only the locking screws, which will be half screws which will be there. So you got to go up, long plate, put a leg if you want to, but a long plate which will have probably 3 screws and it will have a good span. This is what is needed, and not a short plate, because that will always give way. Now here was the second case. Highly successful joint replacement surgeon did this beautiful knee and the patient was all right. Got this fracture, junctional fracture, lower 1/3 and upper 2/3. And did this nailing. Thin, piddly little nail. Even locking is not been there properly. And the fracture is so lower down. This is the part where the nail has no hold, and subchondrally he cannot go because of the knee joint. This is not going to last. We knew it on day 1. It gave way. So ultimately, I went ahead, did a long plate, medial grafting, and things becomes all right. Now here, in a junctional fractures between the upper 2/3 and the expanding lower 1/3, antegrade nailing is contraindicated. Either do a retrograde nail if it is possible, or do a nail and a plate. That is the treatment for that. So if in case surgeon had done an adjuvant plate on day 1, I'm sure he would have been all right. Unfortunately, he wasn't updated enough in order to do it. Probably any one of us doing today, this is what we would have done it on day 1. Day 1, this adjuvant plate would have saved this patient. See, this is the same fracture which is treated, junctional fracture. You can see the whole thing is expanding. It can never be stability. So this is the one, ultimately non-union also we have to treat with the adjuvant plate. This is today what is recommended is junctional fractures treated with the nail and an adjuvant plate. Even if you treat it from a nail from a lower down, if there is an opening in the knee joint, still you will be a thin nail it will be. So it is advisable to put in a nail and a plate on day 1. Orthopedic surgeon's wife, so obviously treated by the best of the person in the city. Junctional fractures at the upper 2/3 femur and lower 1/3 femur where the medullary cavity expands is a poor site for the antegrade nail with 2 screws. Use a distal femur nail or a better antegrade nail and an adjuvant plate on day 1. Unfortunately, the gold medalist missed out this update and patient suffered. Tibia, he got a fracture here, plated. Where is the hold of the upper piece? 2 piddly little screws, only one-sided. There is no hold. And even the fracture like this, without the knee joint, we recommend 2 plates. Here, he didn't have even a bicortical purchase of the proximal segment. So it failed. Only thing which a joint replacement surgeon can do now is to change the prosthesis. So this is what he did. Knee joint which had no problem. Poor chap went through this cycle only because he wasn't fully aware of the trauma science at that time. On day 1, if he had put in a second plate, things would have been all right. Here it is. In even upper 1/3 tibias, we do the same thing. We never treat it with the only one single nail there. We put an adjuvant plate or a double plate, which is required. And you can see here, same thing treated by a similar way by a operating surgeon, could be treated very well with the adjuvant plate secondarily. Didn't need a revision knee at all. After TKR, now there is a fracture here. The dictum all of us know about is, after TKR, the fracture just on or below the flare of the femur if the fracture is there. Single plate is of no use. You got to put in a double plate on day one. This is what is the primary double plating is a must. Because as you can see, this is what went into non-union, so ultimately double plating solved the problem. This was the fracture again, same way, single plating. You can see this is what is moving, because there is no hold on the distal fragment. Now here it is, because why there is no hold? Because once the fracture is like this, fracture is something like this. So when you put a lateral plate, there is only one screw is really holding it to the distal fragment. So if you put into double plating, 3 screws will hold on the other side, 1 screw on this side, so both sides it has been sandwiched. This is the treatment today of a fracture above the knee joint. If it is just at the flare of the femur and slightly below, do not do it only one plate, do it 2 plates. This is again a non-union treated. I remember I saw this patient, non-union completely and treated with the double plating. But you see here what has happened. This was the space. When I did this double plating, I had to compress the fracture. So ultimately, I changed the insert, made a bigger insert. I had to see that it is perfectly matching and change the insert, and the patient is perfectly fine. This is what was done. You can see the original insert was this much. It was made a bigger insert, everything was available, and the patient walked. This is when I went for my tour for the lecture. The patient, I called him in the auditorium, and this is where I have taken the pictures, so it is like this. So last, all the patients were very important doctors in their city or very important people. And just because you are a president of orthopedic society, you are not competent all the time. Just because you are a very good joint specialty surgeon, you are not specialist into other branches. Famous surgeons in the area. Today, I think the tendency is so-and-so has a very big practice. Richness of an orthopedic surgeon doesn't make him competent all the time. Title of a professor, director, ding, ding, ding is all useless unless he has been updated all the time. It's only the constant pursuit of excellence gives you that edge. If you give it up at one stage, you are going to be left behind all the time. And I'll quote now, last, Alvin Toffler, those who have read The Future Shocks, The Third Wave. The illiterate of the 21st century will not be those who cannot read or write, but those who cannot learn, unlearn, and relearn. Thank you, friends.